Welcome to episode 4 of our case webinar series highlighting radiology and community and safety net settings. We will be covering lung cancer screening today. The first part of our discussion will involve health equity and advancing the goals of lung cancer screening in community settings. In the second part, we will cover emerging technologies and new research in the field. I'm Dr. Randy Miles. I'm the Chief of Breast Imaging at Denver Health, the primary safety net hospital of Denver, Colorado. First, a few announcements for medical students. Check out Medical Student Hub, join to access resources, volunteer opportunities, scholarships, and community. The link is below. And then a few deadlines to highlight with the JACR. Here's some awesome opportunities for trainees. Here's information on the JACR Trainee Editorial Board. And then here's the deadline for the Hillman Fellowship for those interested in scholarly publishing. Lastly, if you want to continue this conversation about lung cancer screening in community and safety net settings, please check out Engage. The link again is below. So now let's jump into it. I'm really excited to welcome Dr. Ashley Prosper. She is the section chief of cardiothoracic imaging and co-director of the UCLA lung screening program. She is a researcher. She's an advocate for patients, a real advocate for health equity, so a true expert in the field. So welcome, Dr. Ashley Prosper.
Thank you so much for the warm welcome.
So let's jump into the questions. We do have some patients and some non-healthcare providers, on the feed. So first, can we just do a brief high-level overview of lung cancer screening and the guidelines, whatever you would like to share there?
Absolutely. So lung cancer screening with low-dose CT really has taken off over the last decade or so. My mentor and fellow co-director of the UCLA lung screening program at UCLA, Dr. Denise Aberle, led the National Lung Screening Trial, a randomized control clinical trial in which more than 53,000 individuals were enrolled into a study evaluating the use of low-dose CT of the chest as compared to chest X-ray to screen for lung cancer in high-risk individuals. And what they discovered was that screening with low-dose CT reduced lung cancer mortality in those who received the CT as compared to chest X-ray by about 20%. When it came time to take that clinical trial data and make decisions about how we do this clinically in a real-world setting, the United States Preventative Services Task Force made a recommendation, starting out with criteria that somewhat mirrored the clinical trial eligibility. There's been a somewhat recent update in 2021 looking at the eligibility criteria and updating them. We can talk about how that improves health equity later on. But currently, to be screened for lung cancer with low-dose CT, you need to be at least 50 years of age, have smoked at least 20 pack years. Now, pack years is a little bit of jargon to calculate that. You multiply the number of packs of cigarettes that have been smoked per day times the number of years smoked. The next criterion is that you either need to be a current smoker, or if you've quit, you need to have quit within the last 15 years. Now, the last criterion, I apologize that there are so many that we have to go over, but there is an upper age limit. And what makes it a little bit more complex is that that upper age limit varies depending on your insurance type. Private insurers mirror the USPSTF and go all the way up to age 80, while the Center for Medicaid and Medicare Services determined that 77 years of age was their upper limit cutoff. So as we talk about lung screening and utilization and return to follow-up, I will say that our eligibility criteria are a little bit more complex than probably any other screening exam, and that is one of the challenges that we're trying to address.
And just directed towards patients, if they have questions, they think they may qualify, what do you usually recommend them? Who should they reach out to?
Absolutely. So a great resource is to talk to your primary care physician. Speaking to your physician about eligibility is a great way to start. One of the challenges can be for people to feel comfortable discussing their tobacco use history. And what I try to encourage both our fellow clinicians to discuss, as well as patients to understand, is that we know that tobacco is highly addictive. It would not be so widely used if it were not so addictive. And so there's no shame in discussing tobacco history. If you are able to discuss your tobacco history with your doctor, we can figure out if you're eligible for this screening exam. And if we can screen you, then we have the potential to really improve your outcomes.
So how are we doing? I know you discussed a little bit about how complex the eligibility criteria is compared to other preventative services. How are we doing nationally? And are there specific populations that we need to focus a little bit more attention on?
Thanks for that question, Randy. The National Lung Screening Trial results were published in 2011, and we saw adoption by insurers and USPSTF and insurance coverage around 2014. So we've really reached about a decade of having coverage for lung cancer screening with low-dose CT. And when we look at the utilization rate, it varies a little bit depending on the survey source or depending on how the data was analyzed or which data sources they used. But if we look at the American Lung Association's most recent update on lung cancer screening in America, we're looking around 4.5% of eligible persons who are being screened. Now, that sounds really low, but I want to provide some context in which it still sounds very low. But, I'm sitting here with you, Dr. Miles, who are, you're a breast imager, and you can probably quote this data better than me, but breast cancer screening with mammography enjoys a much better utilization rate, upwards of 70% or 75% or so for eligible women. So we have a long way to go. In terms of populations of particular interest for screening, we're sitting here today to talk about health equity and health disparities. And some of the work that I've done is looking at ways that we might be able to mitigate lung cancer health disparities within the African American community. Currently, African American men have the greatest risk of developing and dying from lung cancer in the United States. And this is something that's really puzzling because this is not due to higher rates of smoking. So when you think about, hazard ratios and risk profiles, while not all lung cancers are caused by smoking, we know that smoking is the greatest modifiable risk for lung cancer. And so you might expect there to be a higher tobacco use rate, but there isn't. What we do know is that in the United States, African Americans, we are more likely to present at a later stage of diagnosis when we are diagnosed with a cancer. And as a result, our outcomes are often not as good. The fortunate thing is when we look at data from the National Lung Screening Trial, that large randomized clinical trial evaluating the efficacy of screening, and we select out the African American participants in the NLST, of which there are about 4% of the clinical trial population, what we see is that the relative reduction in lung cancer mortality for African American participants was the greatest of any group within the NLST. And this is really remarkable because this is a subgroup of the clinical trial population that came in with the highest risk, not only looking at race and associated cancer outcomes in America, but also other characteristics that we know are associated with worse outcomes, such as things like additional medical comorbidities that were higher within this subgroup in the population. So what we have is a test, lung cancer screening with low-dose CT, that can reduce lung cancer mortality across all groups, but particularly is effective for African Americans, as shown in the NLST. But we have very low utilization nationwide. And so one of the things we're trying to figure out is, how do we get this test to more people? How do we make sure that all Americans are aware of the efficacy of this test and increase the rate of people who are eligible getting screened?
Definitely. And I know there's a lot of there's a relationship with some of the things that you're saying with lung cancer screening and then also with breast cancer screening. So I'm curious, what are some of the biggest challenges that you're seeing with routine screening? I know there's like patient level factors or system level factors, but however you want to separate out, what are you seeing that's really preventing a lot of patients from coming in and contributing to that, close to 5% adherence rate?
That's a really important question. One of the researchers who I really admire and I've really loved working with is Lisa Carter-Bawa, and she has a great publication looking at the process of being completely unaware of lung cancer screening to deciding whether or not you're going to participate. And she has sort of a flow chart in this manuscript where it looks at the antecedents, mediators, and outcomes of a discussion about lung cancer screening. And when you look at those antecedents, or those early factors that might indicate how a discussion is going to go, there are sort of categories of things that might affect that outcome. Some being societal. So are we hearing about lung cancer or lung cancer screening in our environment? We just came out of the month of October where we saw a sea of pink. We saw pink ribbons everywhere. And I really commend the breast cancer advocacy community for making sure that everyone knows about breast cancer awareness in October. It turns out that November is Lung Cancer Awareness Month. The ribbon for lung cancer awareness is white, but I don't see a sea of white ribbons being strewn about the malls and supermarkets and all of these things. So that's definitely one factor. There are factors that have to do with demographics. So where an individual lives in the United States, we see that regionally there are different uptake rates depending on where one lives. There are also factors having to do with family history, social history. As we talk about health equity, experiences with racism and medical mistrust. We then go to sort of the mediators of lung cancer screening, pointed out by Lisa Carter-Bawa, things like whether or not a healthcare provider recommends the test, whether or not they're enthusiastic about discussing screening eligibility, and whether or not they have a good relationship of trust with the patient that they're discussing this with. And then, of course, we get to the actual screening exam. How did someone feel when they, say, walked into the radiology department to be greeted to sign in for their CT? How were results conveyed to them? How did they get encouraged to maybe come back for their annual screening CT, right? Because similarly to breast screening, we expect people to come back annually as long as they're eligible. So it's a sea or a multitude of factors. In some ways, it's overwhelming to think about all of the factors, but on the other hand, it provides so many touch points or opportunities that you can either focus on or intervene in.
Yeah, it's so important. I think just bringing up that it is lung cancer lung cancer awareness month. I think it's really important just to point out, if you do have a family member that may potentially be may meet criteria for lung cancer screening, that's a smoker, potentially ask them about, encourage them to ask their doctor about lung cancer screening and to see if they are eligible, or to look up the guidelines, because this is a very important test that has been shown to decrease mortality. So definitely. Let's switch to radiologists, because we know the impact of primary care and how they can support lung cancer screening. But what is the role of radiologists outside of interpreting the exams Do you think we should be playing a larger role, or do you kind of see that already happening, as lung cancer screening has evolved?
You know, I think this is a really important opportunity for radiologists to be involved in the discussion and the carrying out of population health. You know, I think that's one of the things that really attracted me to focusing on lung cancer screening for some of my research is that while we play an incredible role in providing medical care by reading medical imaging, interpreting medical imaging, and for some of us, including yourself, performing biopsies or procedures based on that imaging. And as a result, your typical radiologist is helping, dozens, if not hundreds of people a day by reading those exams. But when you think about the population of eligible screenees in the United States, it's estimated that around 14.5 million Americans are eligible for lung cancer screening. You have an even greater potential to affect healthcare outcomes if you can increase screening utilization. Radiologists, were really at the heart of investigating the efficacy of lung cancer screening, such as, Dr. Aberle, who led the NLST. We're at the center of providing that imaging exam, that low-dose CT exam, interpreting it using our standard ACR developed lung RADS lexicon to interpret those findings and provide management recommendations. And we're often going to be the ones that provide follow-up care for, the small percentage of people who will have suspicious findings and will either need an additional CT, biopsy, PET CT, staging, etc. And so what I really encourage people to do is to think about the multidisciplinary lung screening program and how radiology can facilitate that. I'm really fortunate at my home institution, UCLA, where I do have stakeholders from multidisciplinary specialties. We get together weekly at our multidisciplinary lung nodule conference, and we discuss findings of all of our positive screening CTs with pulmonary medicine, interventional pulmonology, interventional radiology, thoracic surgery, radiation oncology, and we decide together the best recommendations to make going forward for a patient. So that's one thing that we can do. The other is to really take ownership of helping to demystify the screening criteria and make sure that we have strong partnerships within our primary care offices and referrers. So I always volunteer myself to go and give CME talks, to do refresher courses to help make lung cancer screening more manageable for the people who will refer patients to us. I have so much empathy for our primary care physicians who are trying to fit ever more and more and more activities into the same short period of time. I do not think it's fair to say this is entirely your responsibility to figure out who should be screened and make sure that they get to us. We as radiologists can really assist with that.
Yeah, I love that mindset. I think we've seen the same thing with in breast cancer screening, where primary care docs are having to follow so many things, keep up to date with so many guidelines. So whatever you can do to make it easier on them, whether that's through education or siloing some of these processes, so they're not having to, keep up to date with, like when the patient needs to come back, or, making it easier for them to send reminders or schedule patients can be super helpful and really help prevent these patients from being lost from these screening programs. And we know it's super, which is extremely helpful. I know you're at UCLA, and it's a big academic center. You have a lot of resources, but you also have a lot of community sites associated with the hospital. Do you have any advice for community and safety net practices who are saying, we don't have like maybe a navigator, or we don't have a lot of these resources, but we really want to make sure we can optimize our program and increase access. Any advice there?
That's a really important question, and one that I'm still working on the best answer for. So, um, I'll admit to you that while we have dozens of sites, they do all end up being fairly well resourced, right? Because they're under our large academic umbrella. And as I've talked to folks who are at more, really truly safety net institutions, which I grew up in throughout my medical school residency and fellowship training at a safety net, it's a lot more challenging because you do really need dedicated personnel, appropriate software, and abilities to track patients over time, to make sure that you know exactly who's coming in, when they should come back, and that those results are being delivered to them. And so what I will say is we do have some active grant-funded projects where we are working with more traditional safety net institutions to try to not impose best guidelines, but to figure out together the best way to move forward for each individual institution. I think, as I discussed to other people who are doing health equity work, we all end up being very humbled when we try to help to find solutions for some of these challenges. And any solution that you propose really has to be informed by what your safety net providers are telling you, what is possible, what the challenges are, and what they feel are the best ways to solve them. And so we do have several projects working on that. In some of the discussions that I've had, folks are telling me, the resources are not impossible to obtain. They become a lot more available when there is a mandate. So if there is a health quality metric that is being tracked nationwide, say to determine funding for an institution, suddenly doors can open. And so I remain hopeful that as lung screening matures, we will see some of those health quality metrics really take off. And what we do know is that there is a HEDIS measure that is anticipated to be announced or released in the next few months to a year, which will establish a lung cancer screening quality metric. Institutions will be expected to monitor and to report. And I hope that as that measure takes off and people see that this is an incentivized process of tracking your lung screening eligible participants and those who actually receive the exam, that we will see more resources becoming available, because it is challenging if you are under-resourced.
Well, definitely. Thanks for that insight. And I love the fact that you kind of pointed out metrics, data. I think the first step is just kind of understanding how many of these exams you're doing each month, and how you can, even just focus in on, that data point, and just setting goals just to increase that, each month, just because we know we're not reaching as many patients as we can. And then coming from the safety net setting, I do want to kind of encourage safety net and community, radiologists, if you are looking to expand your program, think about partnering with bigger institutions in your city. There's people like Dr. Prosper and other experts, Dr. Flores. So there's a lot of people that come to mind that, they can really help partner, and you can think about some bigger initiatives in terms of, research. A lot of these programs, they need a bigger, diverse pool of patients as they're doing their research projects. So thinking about how you can utilize that to potentially obtain more resources. One of the things that we did in our breast imaging section is that we went to private. We wrote up small grants where we said, we want to establish this particular program. We created a research project out of that, and we were able to fund like a navigator. So you can be very, you can be very creative and think of some unique ways, but it can be very challenging, when you don't have these resources, but there's ways to reach out and collaborate, partner, and also some creative ways to bring in some funding to help support you in your needs. But this is definitely challenging, in these community and safety net settings. So thanks for your expertise in the kind of this health equity realm. We definitely need to do more there, but I'm curious, as we kind of move towards talking about technology and especially emerging technologies, are there emerging technologies available to support these efforts? And I know this is kind of like a broad question, but being an expert, I'm curious to hear your insight. And then what about the role of AI? Is that being utilized to help us in these efforts?
Yeah, this is an area where I'm actively involved with the medical imaging and informatics group at UCLA. I have the opportunity to collaborate with some, brilliant informatics faculty, as well as, doctoral students and postdoctoral students. And so we've tried to work together to figure out some novel ways to improve our identification of individuals who are eligible for lung screening, improving the way that we figure out who's at risk for potentially not coming back on time for their follow-up exam, and trying to make this process more manageable for all. What I'll say, one of my larger hopes is that we will see diffusion of technology through the electronic medical record. And what I mean by that, and again, it gets tied to metrics and quality measures, is as we see more institutions demanding a way to track eligibility, I really hope that this becomes more easily trackable within the EMR. Because in early days, and still in some institutions, you'll hear of people with homegrown spreadsheets trying to track eligible populations of patients and when they need to come back. And that's a great way to start, but it's not super scalable over time as your program really grows. So that's my hope from the vendor side, that we see more of that. I think there is tremendous potential with large language models. I know we talk about GPT all of the time. One of my postdoctoral students, who's brilliant, Dr. Yanan Lin, she has been doing some work looking at how we can use some large language models to better identify individuals who might be eligible for screening that otherwise would be hard to track by looking at just what's been entered in a structured data set in the EMR. And I think that has a lot of potential if we can figure out how best to deploy that. Looking at some of the more novel techniques to figure out things like anticipated rates of follow-up, again with the brilliant Dr. Yanan Lin and Dr. William Hsu, one of my collaborators at UCLA. We've looked at creating modeling using clinical variables extracted from the electronic health record to try to figure out who's at risk for not coming back for their screening exam. We did publish a paper where we looked at our own population of screening patients, and we did figure out that those who have a negative screening exam at their baseline or first scan, negative meaning no suspicious findings were identified, are at risk for not coming back more than those who do have positive findings. And so how does that perhaps, guide the efforts of your staff and your fellow physicians who are hoping to really increase outreach to those who are most at risk for not coming back? I could go on and on, but one of the perhaps slightly farther reaches that we're working on is moving beyond just the imaging to incorporate other biomarkers that might help us to, one, identify who's at risk for developing lung cancer beyond just our rule-based criteria, and two, to help us better figure out which nodules we should really be worried about when we find pulmonary nodules on these screening exams. And we have two brilliant labs at UCLA with NCI-funded grants through the Liquid Biopsy Consortium, looking at biomarkers found in blood, found in saliva, and other biofluids to try to combine that with the medical imaging that we're obtaining to better determine risk of lung cancer. And so these things are not scalable to prime time just yet, but I'm hopeful that we will move in that direction.
Awesome. We just got a question from the audience, which I think we probably can roll in, that kind of relates to this in terms of the harms of lung cancer screening. There are a certain number of patients that you're going to call back for additional imaging, or who are going to have procedures, who end up not, having lung cancer. So can you talk a little bit more about, this medical term that we use in terms of the harms of this screening tool?
Yeah, there are pros and cons to everything that we do in medicine, right? And that's why it's so important to have an informed discussion and a shared decision-making visit with patients before they enroll in screening programs. And some of the things that we talk about are things like false positives. Now, what I will say is what we've done with our various iterations of the ACR lung rads for reporting screening findings is to really try to minimize false positives. For example, it used to be that a positive exam started with a nodule of, size 4 millimeters, and, in current iterations, we're really just focusing on 6 and higher. And that helps to cut out a lot of the small nodules that are very unlikely to be problematic in the next year. Another thing that we think about is the concept of overdiagnosis. And this is a challenging one because it's really hard to calculate how many of the cancers you detect would not have caused harm if you had not discovered them. It's incredibly hard to do because once you establish that a screening exam is beneficial, you don't want to withhold that. That would not be a ethical study to perform. It's also really challenging because we do not, at the current time, have the best ways of determining of all of the nodules which are going to grow more rapidly and which may become more indolent. Even if two nodules look very similar, one may progress a lot more quickly than the other. And so we're still trying to figure that out, including things like incorporating biomarkers. Then there are things that are maybe a little bit easier to understand, like the potential of inducing anxiety. There's a term, scanxiety, that is used, and forgive me, I can't remember who exactly coined the term, but it's real. For individuals who are either anticipating their first screen or their repeat screen, that process of knowing that you have a screening exam or any imaging exam coming up and then waiting for the results can be quite anxiety provoking for some. Sort of lastly, I'll touch upon, radiation exposure. As radiologists, we're really committed to the principle of ALARA, or as low as reasonably achievable, for any medical imaging that we provide. Fortunately, low-dose CT really is low dose. It's a very small amount of radiation as compared to a diagnostic CT or CT angiogram. And that's intentional with the anticipation that individuals will require screening exams annually for a sizable amount of time. And the other positive thing is that we see ever improving technology to really minimize that dose of radiation. We're fortunate in that we recently onboarded a photon counting CT at my institution. We've started to do some of our screening exams on this CT system, and the dose is really a fraction of what we were seeing even with our traditional CT scanners. So I anticipate that that dose will continue to decrease over time.
Definitely. I really have to commend you, and then just kind of the long rads committee really focusing in on, like considering those harms as well. Just with the adjustments to, how you identify and designate, nodules, like being able to reduce that false positive rate. I think it's really important. And I think it's something like definitely on the breast imaging side, we put a lot of focus in on. We're like, we want to call back less women, identify more cancers. But I think it's made a little bit easier on our side because, when we have a patient in clinic, they need a biopsy. We're able to go in and talk to them directly and really talk to them about what we're seeing on the imaging, what are the harms of having the biopsy procedure, which is pretty minimal risk. Whereas I feel like on this lung cancer screening guidelines, you're really put at a disadvantage because a lot of times you're not having that initial conversation. And just hearing all of those great things that you mentioned, I just can't imagine there was just that many primary care docs who can kind of like go through the line and kind of have those discussions. So I did want to kind of I want to come back to the technology part, but are there resources for providers and that, they can access to really have a informed conversation with their patients before they get to like a lung cancer specialist or healthcare provider who has expertise in this field?
Absolutely. And, I will really commend the ACR. This is a JACR session that we're doing. American College of Radiology has really done so much to provide a lung cancer screening toolkit. And the ACR lung screening website is a great place to go. There are a lot of materials available, including guides on how to use lung rads, guides on how to make sure that your CT dose is appropriately low, and a bunch of additional white papers and documents that are really helpful to get people started. There's also a lot of great CME programming available online. And I would encourage anyone in primary care or other non-imaging specialties to really reach out and form partnerships with your radiologists, because I think as radiologists, it's our responsibility to take ownership of this and the responsibility of explaining the radiation exposure involved, because that's under our jurisdiction. Explaining the potential outcomes, what we're going to do with the imaging. Now, at my home institution, we are a very distributed health system. We have sites that span a large geography, and so we've taken some of these resources and we've put them online. We've made some videos and made other digital resources to try to scale this, because I know that I can't physically be at all the scanners where these exams are coming through. And so technology in the form of either digital videos, chat bots. We have a website that facilitates explaining screening eligibility in layman's terms. Some of this technology can really help you spread your message as well.
I love that. Utilizing ACR resources, these toolkits, putting them on your website, and making the providers aware, where these toolkits are located so they can access these tools. So, we're all working together to really try to improve and increase lung cancer screening rates. So I just wanted to see, I know you just were a part of a collaborative group that just, won this like large grant and focused in on this topic. So I want to hear a little bit more about your research, anything else you wanted to share on top of, what you previously shared.
Yeah, I think, as we discussed, all the ways that we can improve lung screening, from, helping to encourage people who are eligible to participate to improving the outcomes once individuals are screened. I've tried to distribute my research efforts sort of across that paradigm. So I have some grant-funded efforts where we're looking to increase screening utilization and awareness. In one of these projects, we're actually trying to leverage the popularity of breast cancer screening or the awareness of breast cancer screening. When we did, or when one of my fellow faculty members polled women who were receiving their breast screening exams, it turned out that a sizable number of them were eligible for lung cancer screening, but had either never heard of it or never considered participating. And so that's a group of potential participants where we can really make a big impact by, say, reaching out to women when they're undergoing breast screening, to take that as an educational moment and as an outreach moment. Another grant-funded project that was just recently awarded, we're going to be partnering with two community hospitals to fund a nurse navigator, a program navigator at these institutions, and to figure out how to really grow the multidisciplinary lung screening program at each of these community hospitals. And we're really excited about these partnerships and to learn from each other. And then I'm fortunate to really work on the informatics side of lung screening with the medical imaging and informatics group. We're employing some of these advanced data science tools to better identify those at risk and to help mitigate risk by using some of the information that we're identifying through the electronic medical record, as well as with some of my collaborators in the basic sciences, where we're trying to pull together what's being done in the laboratory spaces with some of these liquid biomarkers and combining them with some advanced imaging analysis through some deep learning tools and some radiomic analyses to try to bridge this information together. So it's sort of across the whole spectrum. But one of the really exciting opportunities is, to work in what we call team science. I could not do any of these projects by myself, but it's been so encouraging to identify other collaborators at my institution as well as other institutions where we can really put our skill sets together to try to combine them into something even more impactful.
This is pretty amazing. We know this problem of getting eligible patients into the clinic to receive lung cancer screening is multifactorial. So the fact that you're addressing it along the continuum of care is amazing. I did want to bring something back from what you stated earlier that I don't think I gave enough attention to, it just in terms of like utilizing the EMR and making sure that there's ways to track these patients. I think there's been some studies that shown like if primary care doctors don't, provide reminders or if there's no system to remind these patients, then you lose them after that baseline exam, as you, eloquently stated earlier. So, if we're able to kind of focus on these issues in terms of like technology to support us, we really can decrease that human load, or that it will help us to be more efficient in terms of really addressing this issue. In terms of like the AI and radionomics, in terms of like, do you think that can be utilized to help us to focus in on the like false positive rate, help us to better identify which patients actually do need to come back or need to have an intervention? And is there anything that you've seen out there, or anything that you've seen that people have been doing a lot of research on that you're excited about, or you think could potentially help in identifying the appropriate patients to undergo screening?
That's a great question. I think it's a really exciting time right now when we think about what I would categorize as advanced imaging analysis. I have a review paper that I probably should have shared, but I have the link handy, where we look at sort of an overview of all the opportunities within lung screening and early detection. And so I would kind of categorize these into like three broad strokes. Our semantic analysis, where we're really doing what traditionally we as radiologists think about, describing shape, size, texture, solidity of a nodule, right? That comes inherently to us. It's what we're trained to do. requires very few resources aside from human time and labor, right? That training to develop a radiologist to be able to identify these things and describe them appropriately. And then you move on to things like, our traditional radiomics, where we can get some mathematical extraction of data from a nodule that we find, but it may require some manual segmentation or contouring of that nodule from an imaging data set to be able to find it. And there may be some slight differences in the way that, say, my lab here at UCLA that I work with extracts that data versus one that you may work with in Denver and extract that data, just because of slight differences in imaging data. And then you move on to what people are really excited about with deep learning models, where maybe you don't have to even tag a nodule or contour it. You just load a whole CT in and it gives you a risk assessment. And we've seen growth in interest in some of these deep learning models in the last year or two, particularly. And since we are talking about safety nets and health equity, what I'll say to that is, currently we see most of these models coming out of large academic institutions, such as my own. And what we really have to be mindful of is that while we're training, testing, and validating these models, which may become the way of the future for interpreting some of these exams, that our data sets are appropriately diverse and representative of the populations that we're going to serve. And so talking about, academic and community partnerships, that becomes so important as we're talking about this sort of new wave of image interpretation, to make sure that we're not overfitting a model to a very homogeneous population. Also, as we think about, incorporating biomarkers from biofluids, to better interpret some of these results or better provide risk prognostication, again, it becomes so important to make sure that you have a representative population when you're doing these analyses.
Important points. What about policy? I think this is maybe one of the last questions that we asked, but what do you wish policymakers knew about lung cancer screening in traditionally underserved settings? And how can they support us in our efforts to, increase the number of people that are coming in who are eligible and that receive this exam?
Great question, Randy. One of the things I try to focus on when I discuss, information about lung screening and some of the research that we're doing is the potential upside, right? So when we think about lung cancer, there's a lot of sad news, right? Leading cause of cancer-related death in the United States. Most cancers are not being detected early. I try to focus on all of the things that we could achieve together. So the good news is we have a screening test that works. Low-dose screening, lung cancer screening with low-dose CT is incredibly effective. We can reduce mortality by at least 20%, if not more, in some underrepresented groups when we look at data from the NLST. Yes, it's a challenging exam, right? But the payoff is huge if we can make the determination. And what I mean by challenging exam is it's challenging to identify those who are eligible, right? And it's challenging to track them over time. But the potential payoff is enormous, right? If we can reduce deaths from the most deadly cancer in the United States, that is an incredible payoff. And so the resources that we invest as a country, as state and local, government and policymakers, that investment has the ability to really pay off so much in the long run. And we have the data to back that up. And we have the experience, and we're, ever evolving and improving this exam over time. So I would tell them that this is a worthy investment with a high yield return if we can decide to focus on this together.
Awesome. And then we'll take our last question from the audience. It looks like we have a question from the chat from Corey Thompson. I understand that in March of 2021, the lung cancer screening guidelines were expanded to increase eligibility criteria. Have we seen the effects of these changes at the patient-provider level?
I'm glad you gave me the opportunity to answer this, Corey, because it's really important, particularly as we think about health equity and reducing lung cancer health disparities. So when I went over the lung screening criteria, I did recite the 2021 criteria. And I'll briefly tell you what changed from the preceding version. And that was lowering the age of eligibility from what was 55 years of age down to current guidelines of 50, and those tobacco requirements of consumption of 30 pack years to our current 20 pack years. And why this is so important is when analyses were done looking at the efficacy of the prior guidelines, some reports were coming out of real world lung screening populations. One of the leading papers was the Southern Community Cohort Trial, where they looked at a large population, I think over 40,000, don't quote me, but a large number of individuals. And they looked at those who developed lung cancer, and they said, would they have been eligible for lung screening before they developed their lung cancer? And it turned out that African Americans within this cohort were developing lung cancer before they ever met the age or smoking history requirements required to be screened for lung cancer. And so enough people started to really talk about this that we saw changes in the guidelines, lowering the age of eligibility and lowering the pack year requirements, so that we do see increases in eligibility for our African American current and former smokers, as well as for women who were not being included enough in the prior guidelines. So, these guidelines did change. It did require us to remember a new set of eligibility criteria, but it has resulted in nearly a doubling of the number of Americans who are eligible and increased eligibility for our African American population, who experiences the highest burden of lung cancer in this country in terms of risk of developing lung cancer and dying from it, as well as for women. And so this is a huge improvement.
And just to finish it up, it's Lung Cancer Awareness Month. Dr. Prosper is expert. Do you have any final thoughts or words, or anything that you wanted to relay to the audience?
Yeah, I think this is a really exciting opportunity for radiologists to engage with their local community, to renew partnerships with their primary care referrers, and to take an opportunity to go over the guidelines for lung cancer screening and to examine our own local efforts in terms of what we're doing to advance our screening programs at our local institutions. I think there's a lot of opportunities to engage not only fellow healthcare providers and community organizations, but for example, medical students and undergraduate students. I've had a lot of enthusiastic participation from local undergraduate chapters of the American Lung Cancer Screening Initiative at my institution, who have been fantastic in organizing lung cancer awareness walks and painting white ribbons to distribute to our lung cancer survivors and our lung cancer champions locally. So look for opportunities to partner. I know we're all busy trying to get through our work lists and reading as many exams as we can to provide that care to as many patients as we can, but you don't have to do it all yourself. You can form strategic and really beneficial partnerships where you, your primary care providers, your community partners, your local students all benefit and are able to really advance this work.
Thank you so much, Dr. Prosper. Next, I just want to give a special shout out to the University of Colorado Radiology Residency for some of those great questions. I also want to point out that we do have some papers from JACR in the chat. A few of these, all these papers I've kind of gone through, and they're really interesting on lung cancer screening. One by Tina Taylor and the group at Duke, that was published in JACR. They looked at lung cancer screening and clinical practice Another one which include Dr. Prosper was one of the authors, where looking at the ACR lung rats version 2022, looked at assessment categories and management recommendations. And then we've also copied in some papers that look at lung cancer screening outreach in some of these underserved settings, utilizing mobile CT scanners, and also looking at setting up clinics in these rural areas, such as in Arkansas. So really, please check out those articles. We're also going to copy in and paste some articles from Dr. Prosper, who is an expert in the field. So thank you so much for joining us. Our next session will be in January, where we will be covering international talk about international health and radiology. So look forward to seeing you then. Thank you so much.